Well, good afternoon, everyone, and we appreciate you taking time to join us this afternoon in the midst of what we know are busy schedules for everybody across the state. But we've got a great agenda put together today to help dive in a bit more to what's going on in the retiree benefits space, specific to retiree healthcare, in light of the evolution of the Inflation Reduction Act and the impacts that's going to have, particularly around retiree healthcare and the pharmacy piece of that. So we have our colleague Gail Levenson here with us today. She's going to be talking with us through that element, and also have a second colleague, Kevin Spanier, who will spend some time at the end of the webinar talking about pension finance and some of the hot topics that we're seeing there, and some things that we think are really timely and important for you all as Michigan County employers. And so as we dive in today, I'm going to see if I can get this slide to advance. This gives you a quick overview of our presenters. Also joining today is Jeff Nielsen. He's an area vice president on our public sector team here in Michigan, and myself, Chad Hodkinson. I think I know many of you that are joining today, senior area vice president with Gallagher. I lead our public sector practice, the public sector market here in Michigan for Gallagher. So just a quick snapshot before I hand it over to Gail. When we look at Gallagher as an organization, just to be sure that all you who are joining are familiar, Gallagher, I like to say, has a global presence with a very local presence here in Michigan. So global reach, local presence. So we've been around for almost 100 years. We're the third largest insurance brokerage in the world. But over on the right-hand side, we maintain a very local presence here in Michigan, working with many of you and your colleague counties and municipal organizations across the state, really supporting at the core the establishment and driving of strategy specific to your benefit program. So medical, dental, vision, life, disability, not just for your actives, but for your retirees as well. But you'll see in the middle a host of other capabilities that we're able to bring together collectively as an organization. And so as we dive in, I'm going to hand it over to Gail, and she's going to really dig into the retiree drug coverage space and what we're seeing developing in that space. So Gail?
Hi, everybody. As Chad indicated, my name is Gail Levenson. I am a pharmacist by background. I have more than 30 years experience, although I know everybody's looking and going, that's not possible because you look like you're 39. But I know it does happen. This is a huge area, and I'm going to try to make it as simple as possible and highlight the areas that are most important. But over the course of the next, 30 to 40 minutes, what we're going to talk about is Medicare Part D, where it's come from and where it's going to. And then we're going to get a little bit more detail into Retiree Drug Subsidy, employer group waiver plans. And then as Chad indicated, the Inflation Reduction Act is having a significant impact on retiree Medicare coverage in general, both on the Medicare AB side of the Medicare Advantage side, as well as the Part D side, and then some key takeaways. If you have questions, please put them in the chat. And my understanding is we're going to go through those in the after both myself and Kevin have presented. So anyway, we're going to get started talking about Medicare. It's one of my favorite topics. So why don't we go to the next slide? And this is sort of talking about, where did this come from? So in 2003, the Medicare Modernization Act was signed. And what it did is it made provisions to implement the first Medicare Part D drug plans for 2006, as well as Retiree Drug Subsidy. And we'll talk a little bit about the difference in those and why some employers are stayed in Retiree Drug Subsidy, or RDS, as I'll call it, or Medicare Part D, which in a situation of people that have group plans would be EGWP, Employer Group Waiver Plan. So we're going to talk a little bit about that. In 2010, the Patient Protection and Affordable Care Act was initiated. Over the course of the 10 years, the infamous donut hole or coverage gap closed. So it started with the legislation in 2010, and in 2020 was the final elimination and closing, and I'm going to see a closing, in quotes, of that donut hole or coverage gap. And then just last spring of 22, actually, I'm sorry, correction, fall of 22, the Inflation Reduction Act was signed into law that required significant changes to Medicare funding, Medicare plan design, for both perspective of a better opportunity for the individual population to enroll and not to spend thousands and thousands of dollars anymore, as well as making sure that pharmaceutical manufacturers kind of had a little more skin in the game and had some sort of parameters that they needed to follow. So let's go to the next slide. So just a quick refresher, and I am focusing primarily on Medicare eligible retirees today. I will make a couple comments at the end about pre-65 retirees because there are some impacts as people are aging in, but the focus really is going to be on those age 65 and older folks that are Medicare eligible, that are retired, because if they're still working, they're not eligible for Medicare, right? So we're just talking about retirees. Medicare Part A has been around forever. It covers hospitals. Medicare Part B is medical. That's things like physician offices, some prescription drugs, durable medical equipment. There's a lot that fall under that Part B as in boy. If you add A and B together, you get a C, which is the Medicare Advantage plan. And that is a plan that kind of looks like any type of other plan, like a PPO plan that you would offer. It has, may have a deductible, co-pays for different levels of service, et cetera. But it's managed as one plan. And those are all contracted through private health insurers, right? Medicare does nothing related to Medicare Advantage. They just fund the health insurers. Part D is the drug portion, and that's the portion I'm going to spend a significant amount of time today, although I do have expertise in C if you have questions relative to Medicare Advantage. Some of the things I talk about relative to Medicare D will also apply to Medicare C or Medicare Advantage, and I will certainly let you know of that. No, you were good. Keep going. So retiree drug subsidy, as I indicated in 2003, when the Medicare Modernization Act was signed, in addition to implementing a Medicare Part D plan, there was a decision made that said, we want employers to keep their retirees. How can we incent them? So they implemented a retiree drug subsidy program where employers could maintain their current drug coverage, current plan design. They would have to do nothing. The only thing employers would do is say to their retirees, do not enroll in Medicare Part D, because if you do, our enrollment ceases to exist. That was it. So no plan designs. The only thing they'd have to do is show actuarial equivalence based upon the Medicare plan design, which, as we will talk about, was very, very not difficult to achieve at that point because of the coverage gap. Different from Medicare Part D plans, a lot of the compliance responsibility sits on the employer, right? Because you have to be responsible for all of that information, all of that maintaining information, et cetera. Over time, right? It was a great program. You got reimbursed up to 28% within a certain spend corridor. Perfect option initially. Then they started to change and say, oh, that's going to be taxable income now. So we're no longer, it used to be tax-free, but now it's going to be taxable. And as part of other legislation that passed, we're also going to impose a 2% sequestration on that. So as the RDS plans evolved, as well as the Medicare Part D plan, employers started to make decisions relative to, should we stay in RDS, or are we just not getting the bang for our buck anymore? And because retiree medical is so expensive, and the majority of the cost on the retiree medical side is going to be on pharmacy, right? So unlike in your active and pre-65 populations, if you combine them, it's usually completely opposite, 80% RX, 20% medical on the on the post-65 side. Next slide. So in 2006, when the EGWP was first implemented, people were afraid because there was a lot of unknowns relative to employer group waiver plans and Medicare Part D. There was some requirements that a lot of employers just weren't comfortable with. So a lot of employers did not implement initially. I happen to be at an employer who did. So I implemented my first employer group waiver plan in 1/1 of 2006. So hence why I'm still talking about it. And I will tell you that it was painful. It was a painful process because Medicare has a ton of communications and things like that. People didn't understand, right, et cetera. But what ended up happening over the course of several years was that the EGWP became much more attractive as the donut hole closed. So let's go to the next slide. And I'm not spending a lot of time on this background, but I think it's important for people to know what the difference is between an EGWP, if you do have an EGWP or don't, and a standard Part D plan that's in the that's available nationally, right? So in an EGWP, you're contracting with your PBM. Your PBM holds the Medicare agreement. So all of the compliance that you have is now no longer on you if you had RDS. It's now on your PBM or health plan, depending upon what you do. You have the ability to completely match your current plan design between a Medicare Part D standard plan and any enhanced coverage or wrap coverage that you would like to include. So anything that's not covered by Medicare, things that it buys down copays, it really makes the plan complete. So you can cover 100% of drugs. I think that's the number one misnomer that people have is that, well, it's a Medicare plan and Medicare doesn't cover everything. You can do that on an EGWP, first thing. As the coverage gap started to close, this wrap came into play. And I'm not going to go into too much detail to just say we were able to access a lot more subsidy monies as a result of the wrap. So not only are we getting a monthly subsidy on right, so from a financial perspective, RDS, most file annually, you're going to get money in every single month, right? You're going to get in a monthly subsidy amount. You're going to get in a prospective catastrophic reinsurance amount. You're going to get in a quarterly covered gap or pharmaceutical manufacturer discount amount. By the way, that is separate from rebates that you would be receiving through your plan as well. So again, this is a great way to access a ton more revenue to buy down the cost of your plan. Next. So just a couple other things. The one thing that I think people were concerned about was ID cards. Like, oh, I can't give another ID card. You tell me there's two plans. No. Now, it's one ID card. And by the way, most health plans will even allow you to put the pharmacy information on the ID card. So you could actually have, by the way, a fully insured Medicare Advantage and a self-funded EGWP by two different carriers, and they would put it on one card for you. So again, it's a single transaction. So even though I told you there's a primary and a secondary wrap, that's not what's seen with the member. The member is going to go into the pharmacy. They're going to hand their ID card. It's going to adjudicate that claim, and then they're going to pay their copay. Very simple. So we like to say the disruption is not zero because there's not. There's always going to be a potential, confusion. Things like it's a different formulary. So if you have a 3-tier plan design, you could have a drug identified as a second tier now that may go to a third tier. So that could be considered disruption, right? There are some required CMS mandated utilization management programs. Those programs are something you can opt out of, but they're all safety and health related. And my guess is anybody who has a prescription plan in place now probably already has these in place. And again, the most important part is all of that Medicare responsibility that you're doing for RDS goes away. Obviously, for the reopening periods and the years as you're doing reconciliation would remain on you. But from a Medicare compliance moving forward, it would no longer be an issue for you. It would be an issue for the PBMs. Next slide. So this is for 2024. And I like this slide because I'm a visual person. And it just talks a little bit about understanding how the Medicare plan works. And then I'll talk to you a little about, again, how the wrap, right? So Medicare comes out with all of these major sort of announced changes annually. And they do that sometime mid-year where they'll say the deductible for 2025 is X. The out-of-pocket max is Y. And so what these are was for this year alone, Medicare had a $545 deductible. That does not mean that your members have to pay a $545 deductible. That's where the wrap kicks in. If the wrap says, oh, they pay a $10 copay for generics from the very beginning. They pay a $10 copay. There is no deductible. So again, this is the primary plan, but the secondary plan compensates and makes it mirrored to your plan. I have clients that have deductibles, but let's say they have $200 deductibles. It would apply that way. Once somebody hits that deductible, they go into this phase right here, which you can't see because obviously I'm not showing my screen, but it's the plan pays co-insurance here. So plan pays 75%. The retiree pays 25%. That is this second little step up. And that again has to do with the initial coverage level. Once somebody hits the initial coverage level, they go into the coverage gap phase. And that coverage gap phase, or donut hole, is those next two blocks, right, where it says brand and generic. And for brand drugs in the donut holes, you get back 70% of the cost of those drugs on a quarterly basis. So on a $100 drug, $70 of it would be reimbursed back to you on a quarterly basis. I have to be honest, it's a win, right? You're not getting any of that from RDS. For generics, obviously, there is no additional pharma discount. Once somebody hits what Medicare calls now Medicare true out-of-pocket max, that would be this $8,000 right here. Once somebody hits Medicare true out-of-pocket max, which by the way happens quite frequently by mid-year based on how the Medicare accumulators track, they hit catastrophic reinsurance. When somebody hits catastrophic reinsurance, they pay nothing. So again, I just wanted to kind of talk through, because I'm going to talk about changes in the Inflation Reduction Act. And to me, it's good to have sort of a good idea of what's happening this year before we talk about what's happening next year. Next slide. Perfect. Let's go into the Inflation Reduction Act. So as I indicated, oh, I was right. Spring of 22. I don't know why I thought it was fall. Spring of 22, the final rule was released relative to the Inflation Reduction Act. That rule gets thrown over the wall to Medicare, and Medicare has to now implement this multi-tier strategy. They don't know at this point what they're going to do, right? Because at this point, they see what has to be accomplished, but they are absolutely not in a situation ready to be able to do that. So as I talk through this, I'm going to make comments about, yeah, there's no final rule in this. There's no final, because guess what? Stuff for 2025 is still not happening. We still are looking for some responses from Medicare. But a couple areas that was super important, right, was the first thing that was implemented was inflation rebates. And what that is inflation rebates are rebates that are paid by pharmaceutical manufacturers if they increase the cost of those drugs over the rate of inflation. And in that situation, those rebates are paid back into the Medicare program, and Medicare uses those to offset costs. Doesn't come back to the employers, et cetera. But it certainly is a great way to maybe manage those pharmas a little bit more closely and also ensuring that Medicare continues to be funded. So that happens. It started in 2022. When you look at the 2023 column, the most important thing that happened was the $35 per 30-day supply insulin cap. And if you're familiar, insulin is now basically maxed out everywhere at $35 per 30-day supply. That pretty much mirrors what Medicare required. It requires all vaccines that are eligible for Part D coverage to be covered at zero cost share. Most employers were following ACA and were already charging zero for the majority of vaccines, but now this is requiring it. If you have Part D coverage, you have to give your vaccines at zero cost share. I'm not going to get into a lot of the financials behind the scenes, but all the plans were made whole for these two specific things. When you go to 24, so now we're in 24, right? What happened? Well, the two things that happened in 23 that I just talked to you about, the vaccines as well as the $35 insulin cap, will now remain in place. They don't go away. And now the most important thing is Medicare said, once somebody hits catastrophic coverage, they pay zero. The other thing that happened is that there is a low-income subsidy program that supports members that are within a certain economic income. They increased the expansion and eligibility to 150% of the federal poverty level, and anyone who qualifies gets that 100% subsidy from Medicare. What that means is they get the plan gets back about $33 to $34 per month for that member, and they also subsidize their copays. So it's a great help for people that are certain to are eligible for this, that need to take a lot of medication. The last thing has to do with premium stabilization. It's really primarily focused on the individual market. It is not an EGWP specific requirement, because most EGWPs are already subsidizing their employer group waiver plans and their Medicare Advantages, so there's not really such an issue for you. Now we get into 25, and literally the Medicare plan is blowing up, right? So everything I talked to you about earlier is no longer relevant, and I'm going to walk you through on the next slide, after I go through this slide, sort of what that means from a perspective of what does it mean to retirees and to plans that offer these. So again, there's a $2,000 out-of-pocket max, but it's really not an out-of-pocket max the way we think of out-of-pocket maxes, and I'll talk a little bit more about that. The CGDP, that's the Coverage Gap Discount Program, that's sunsetting. So that 70% that I talked to you about is going away and being replaced with additional subsidies, which I'll share in the next slide. Federal reinsurance used to be subsidized by Medicare specifically at 80%. Now it's going to 20% for Medicare and 20% for pharmaceutical manufacturers. And so that is a big change. And then the last one, which is honestly is still kind of figuring out, is something called copay smoothing. What that means is if somebody has prescription drugs that cost more than X per dollars that they would have to pay for at the pharmacy, then they are eligible to have a almost like a loan to pay off more slowly over the course of the year. That is still being figured out, but there are certainly a couple things to just make note of. My understanding so far is that what happens is that the pharmacy would be notified that the member was eligible for this copay smoothing because of the cost of their prescription drugs, and that it would actually occur at the time of sale of the prescriptions, and then the retiree would pay over the course of several months. There is something in the legislation relative to bad debt, which again, nobody seems to be able to tell me what that looks like yet. So at what point is somebody bad debt? Is the employer responsible for that bad debt? My only understanding is if somebody is enrolled and isn't paying, they can be disenrolled from this copay smoothing program, but they are not disenrolled from Medicare. So that's sort of 2025, and I'll walk through a little bit more changes in the next slide. But 2026 is another one which we're like, wow. Medicare has announced it's 10 drugs that they're negotiating on behalf of the plan. The question is, what are they negotiating? Are they negotiating net cost? Are they negotiating cost before rebates? Are they negotiating no rebates? How is that going to be addressed via adjudicating of claims? How is it going to be addressed via contracting with your PBMs or health plans? We don't know. So that to me is the biggest unknown, is what's going to happen in 26. With that said, the number one drug that they are going to be negotiating is Eliquis. And Eliquis is the number one spend by billions of dollars. And so they will be negotiating on Eliquis and some insulins and a couple drugs that are used for inflammatory disease, specialty, et cetera. So that list is out there. It's easily, if you're interested, you can message us and we can certainly share the list of drugs that are impacted, and we can even share the process that Medicare is going through to be able to negotiate those. Next slide. So the left side here where it says current is actually 2023. The only difference between 23 and 24 was in the top row where it says 5%, the 5% goes away. So now for 24, the Medicare is a reimbursement at 80% and the plan picks up 20%. That's sort of the share right now. So just other than that column, the graph on the left is accurate. Now we go to 25, right? The first thing is the deductible, right? Then we're going to hit the initial coverage level. So we still have an initial coverage level, but what you see is that the coverage gap that you see on the one side is no longer there. during the initial coverage level, there is a 65% plan responsibility, 25% retiree responsibility, and 10% pharma responsibility. Again, this is behind the scenes, and your plan would re-adjudicate or wrap around this Medicare plan, but this is the plan that will be in effect. Once somebody hits catastrophic, right, pharma will give 20%, Medicare will reimburse 20%, and the plan will cover 60%. So for people that currently have or participated in Group Waiver Plans or MAPDs, you are impacted by that because this is going to be in effect for next year. There's other sort of nuances that happen that EGWP does have a couple more potential options relative to this, but as from a perspective of the design, this is the design for 2025 and beyond. Next slide. So what's the good news? So now pharma is going to have some skin in the game. If they raise their prices more than inflation, then they are paying rebates back to the Medicare plan. Certainly, the first 10 drugs to negotiate is a hugely, we believe, impactful. But we again don't know what that looks like yet to know the financial savings of that. And then what the actuaries are telling me is that long term, we think there's going to be a reduced trend on Medicare costs. Bad news, short term, definitely higher Medicare costs in 2025. We do expect to see a reduction in funding. As I indicated, coverage gap is being reduced, pharma manufacturers being reduced, some stuff is shifting, but at the end of the day, there will be some shifting of funding. The one thing I didn't mention here is with the changes to these plans, the monthly subsidy amount is expected to go up significantly. So we would see and that's what you're getting on a monthly basis. Similar, it's like a capitated amount based upon the risk score of your individual retirees. So you definitely will see a significant swing in the other direction. So even though some of these other external sources are reducing, there will be a significant swing. We just don't know at the end of the day what that looks like, because the other thing which is not really part of this discussion is your normal pharmacy trend. My guess is everybody knows what a GLP-1 is, right? Ozempic. People are seeing significant increases in overall spend as a result of that GLP-1 class. And because of that, the trends for 23 over 24 are expected to increase by about 20%. So we're expecting to see that, which again, isn't really accounted for in any of the external funding. Next slide. So RDS. So again, talking a little bit about RDS, right? One of the biggest things, and I think the biggest concern right now, is that RDS, the Retiree Drug Subsidy, requires that your prescription plan, right, go through an actuarial equivalence testing process. The expectation is, because of the new plan design, there will be a significant amount of plans that will fail. So if they fail, then they are eligible for zero subsidy. So what I would say is, if you have an RDS plan now, I would certainly ask your actuary to run some information for you to see how you're performing and if you will continue to pass. But that's the biggest concern for RDS. Okay, go ahead. Thank you. How about related to EGWP and MAPD? As I talked to you about, right, we do see an increase in our EGWP on the RX side for EGWPs, as well as MAPDs, which are fully insured. And we expect that to happen by virtue of lower federal subsidies and lower pharma subsidies. With, again, the comment for 26 being the negotiated drugs, we do expect that would have a pretty material effect. We just don't know what that looks like yet. So again, as you see here, there is some direct subsidy, significant increases that will help you. But again, we just don't know with everything else that's happening and the reassessment, by the way, because they are reassessing and sort of rebalancing risk scores. So although you are going to go up on a per member per month basis, they're actually splitting groups a little bit now and looking at the low income subsidy people separately. So we are going to start to see even a little bit of a moderation in the risk scores. So the risk score may be a little slightly lower, but your funding will be significantly higher. Next slide. So this is just a nice sort of way to look at it, right? What is the impact on plan sponsors? If you happen to have a catastrophic HRA for your plan, you're not going to need it after 23. So if you have one, you need to get rid of it because there is no more catastrophic. So that one goes away, right? We already talked about how EGWP financing is going to be impacted. RDS subsidies, we've already talked about, going to be harder to qualify. And in addition to that, you're not going to get as much funding just on because of the change of how the Medicare plan is working. And then credible coverage. And credible coverage, as a reminder, is really, you need to do credible coverage testing for any plan that has people that are aged Medicare eligible, so age 65 and older, that are still working, and people that are aging in to Medicare, so like the pre-65 retirees. The new guidance is saying that they're going to have to do credible coverage attestations against the new Medicare plan. So that's just another area. And there is actually a piece that we're going to share after the webinar, which was a buck piece that we put out relative to the challenge relative to credible coverage and what some clients or some employers may need to do to make sure their plans are credible. Next. So what are the key takeaways? So that was a lot of information, right? I would say, first off, retirees are becoming more and more expensive, right? If you have retirees that are not in an employer group waiver plan, so they're in your commercial plan, and commercial is sort of a generic term, right? A, they may not qualify for RDS, right? B, they're going to have higher trend, right? Because we've already talked about what's happening in the pharmacy market, and you're not going to benefit from any of the price controls that I talk about. So Medicare is not negotiating on behalf of the commercial population. They're negotiating on behalf of themselves, right? So only people in the EGWP plan. So you would not get any of those financial benefits. If you're an EGWP or MAPD, right, we're going to see a reduction in subsidies, which may increase your overall costs, right? Could have GASB impacts, right, as a result of that. And again, not an actuary, so I'm going to not answer any questions as it relates to that. But if you have questions, Kevin's on the phone. And then we do expect long-term that there'll be RX, we'll see some decline in RX trend as sort of everything gets implemented and the market levels out. On the active commercial plan, as I said to you, you may not pass credible coverage. You need to make sure that your plan is credible compared to the new Medicare Part D plan. Now, my understanding is there is some appeals in the works to try to get that specific requirement reversed. But as of now, it is still in place. And again, we have a piece on that. And again, you may also be subject to some higher trending due to some cost shifting. So that was a lot. If you have questions, please put them in the chat. If you're interested in talking to us, there'll be contact information at the back of the presentation where you can send an email and we can coordinate a call. But thank you. It's been a pleasure to present to you. And I'm going to turn this over to Kevin.
And Gail, real quickly, before we have Kevin starting to chime in, because we're doing well on time, I'm going to put you a little bit on the spot here. We have a little bit of time for a bit of Q&A now on this topic while it's fresh for folks who are participating. Again, I would reiterate, if you have questions specific to what Gail just shared, if you want to throw that into the chat, we can field those questions now with her before we bring Kevin on to talk more from through the pension lens. But as we talk about it getting more difficult to satisfy the creditable coverage benchmarks, right? Are there a scenario or two that you could provide as examples for counties that are participating today with plans that they have in place today that may make things more than less difficult to prove creditable coverage or achieve creditable coverage?
Yeah, I would say the number one is anybody that has a high deductible health plan will fail. So I can pretty much say that across the board. I'm pretty much, so if you have an HDHP and you have active over 65 Medicare eligible people, or you have your pre-65 retirees in an HDHP, it will not meet credible coverage. I would say that's your biggest takeaway. And that one would mean, and this is what I suggest people do. So here's your sort of my initial thought would be create a plan that mirrors a Medicare Part D plan design that you would want for your retirees, and put the people as at age 65 in it. They can no longer be eligible. I would tell them they're not eligible, because it ends up being a problem for them, by the way. So if somebody's not in a credible prescription drug plan, once they move to Medicare, they pay a penalty. So if you could keep them in an HDHP, but if somebody works to 67 or 68 and he was eligible and for 3 years, it would be 36 times the 1% of the Medicare premium that they would have to pay in addition every month for that. So that would be, something. If you were going to do that, then I would suggest a communication to let people understand that, and give people an option to enroll in a plan that is going to hit that, be able to meet credible coverage. So, okay.
So a little bit scary. But again, we're sitting here in March, so we've got time to plan and anticipate and pivot, right? So, um, what would be, maybe to reiterate, somebody who has a retiree drug subsidy program in place today, any quick hit considerations or kind of key takeaways to reiterate there?
Yeah, I would just say for RDS is that you need to go through the actuarial attestation process and see if your plan is credible, and will it fail? Because if it fails, you need to know that. Now, I know that the timing wise, you still have time, right? I know that Buck does a lot of the attestations more so in the late summer, fallish timeframe, but it would be kind of good to know if there's a possibility of you failing. Now, arguably, public sector plans offer much more generous benefits than a lot of employers out there. So if you happen to have a very generous plan design, you may not, but it would need to really be tested to confirm that. So that would be my first comment. If you're big enough, and that could be depending upon what you're doing, you could do an MAPD through your health plan, right, very quickly if you wanted to do something like that. It's not the most transparent, but it would bring you in more value, and they would take on a lot of that responsibility. So that would be my other quick hit, but it's so dependent on your plan design, your premium strategy. It's hard for me to just make general comments.
Yeah.
Yeah.
And I knew I was putting you a little bit on the spot,
Yeah,
but I
no
just want
problems.
for participants on the line, I think I hope everyone, as a key takeaway, if you have you know Medicare Advantage programs in place today, this is really going to require action as we go through 2024 and you're preparing for 2025.
Yeah, I would say, Kevin, I would say, Chad, anything related, anybody who covers Medicare eligible retirees,
Yeah,
right? They may not have a Medicare plan today, but Medicare eligible retirees needs to really rethink the process of how they're handling those now.
yeah,
Yeah.
absolutely, absolutely. So fantastic! Thank you so much, Gail, for being with us, and I know you'll be hanging on for additional Q&A here at the end of the session. So I am going to turn it over to Kevin. Kevin, if you want to come off mute, and I'll get the slides advanced here, and talk to us a little bit about where we are through a pension lens today, and this Michigan Public Act 202.
Awesome. Thank you, Chad. And thank you for the opportunity to come speak with you today. So, when Chad reached out to me and asked me to come spend a few minutes with you all for some hot topics, I came back to him with this Pension Act that went into effect back in 2017. And Chad was like, I was thinking a little more recent than that, but there is some provision. There's one provision in particular that I wanted to talk to you about today that you may not have acted on yet because you had time when that law went into effect to actually go in to do this provision. So uh, the Act 202 of 2017 went into effect on July 1, 2018, and it had a lot of different requirements, and a lot of those requirements you're already doing today. But the one I wanted to focus on was for an actuarial audit. So the act requires all local governments to complete at least once every 8 years, either an actuarial audit that's conducted by an actuary that is not the plan actuary, or replace the plan actuary. I think everyone on the phone that has a pension plan probably understands what it means to replace the plan actuary. So we're not going to really dive into that one. But I wanted to spend a minute to talk to you about actuarial audits and what does that mean? What is the process? What do you need to be thinking about when you go to do an actuarial audit? So actuarial audits, there are three primary types of actuarial audits. If we can advance to slide 1. So the GFOA tells us that there are three basic types of actuarial audits, and really it's the scope and the depth of the audit determines which level you're doing. So a level 1 audit, that would be where you engage an outside actuary to come in and do a full replication of your current actuary's valuation. So your current actuary has completed your valuation. They've provided you all of the actuarial information. They've given you your contribution rates. That's done. Now you have an outside actuarial firm come in and they replicate that process. So they'll get the census data, they'll get information from your current actuary, they'll look at the assumptions and methods being used, and they'll see if they calculate the same liability, the same contribution rates, or something reasonably close. So it's a check to make sure that your actuary is actually calculating the benefits appropriately and providing you the information that they say they're providing you. So that's a level 1 audit. A level 2 audit is a little less invasive. It's instead of this outside actuarial firm coming in and providing you with a full replication of that valuation, they will just do a sampling. So they may pull different members and say, okay, we want to look at these members, make sure that they're being valued correctly, and then we can interpolate and say, okay, then if these guys are correct, then it's probably correct for everyone, or we found some issues. So that's a level 2 audit. And then there's a level 3 audit, which doesn't actually require the reviewing actuary to do any kind of actuarial calculation. So I'm not going to collect data. We're not going to replicate the valuation results. We're just going to review the report. So we're going to take the report that was given to you by your current actuary. We're going to review it for actuarial standards. We're going to review it for internal consistencies and reasonableness, and then we're going to opine on our findings. So a couple key takeaways for you is this is required to be completed within 8 years since the law went into effect on July 1, 2018. That would imply that you need to have an actual audit or replace your actuary within the 8-year period between July 1, 2018 and June 30th, 2026. It will take you time to go through the procurement process of your county to hire an outside actuarial firm and for them to actually complete this audit. So I wouldn't wait to the last minute to do this requirement. It's going to take you some time. It's probably something you would want to think about doing in 2025. And also, you would want to speak with your legal counsel for the plan, because the law, the way I read it, which I am not a lawyer, I'm just a humble actuary, but the law doesn't actually specify what kind of level of audit you need to complete. So you would want to talk with your ERISA counsel to determine which level of audit you should be completing. So just wanted to make sure you guys were thinking ahead. This is something you probably need to do in 2025, or at least be thinking about how you're going to satisfy this requirement. So that's actuarial audits. Chad, if we'll go ahead and jump to the next one. The other hot topic that I would just thought I'd bring to you guys' attention is about an actuarial standard of practice. So actuarial standards of practice are kind of the rule book that all actuaries follow in performing actuarial services here in the United States. And there's different ASOPs, or actuarial standards of practice, that apply to different types of actuarial services. So the particular one we're talking about today is ASOP 4. And ASOP 4 is really looking at the valuations for pension plans. It was revised in December of 2021 and became effective for valuations completed and for valuation dates after February 15th, 2023. So really, it's probably your most recent valuation, or the one that your actuary is working on right now. It has a couple different provisions, but the one that we're going to talk about first is this thing called the LD-ROM. Now, actuaries love acronyms. I've got 2 acronyms on this page you've probably never even seen before. So LD-ROM is a low default risk obligation measure. That's a mouthful. And it's a new kind of liability that we're going to have to just start disclosing in all of our valuation reports. So if we flip to the next slide, Chad, what in the world is this LD-ROM thing that Kevin's talking about? So the LD-ROM is meant to calculate the liability if the assets were invested in a lower default risk type of investment strategy. So what your actuary is doing is today you are invested in very different kinds of assets, right? You've got equities, you got fixed incomes, but each one of those asset mix comes up with an expected return. And then we use that expected return to discount your projected benefit payments back to today to come up with a present value, or a liability as we call it. So what's going to be required now through our ASOPs is we're going to have to do a new liability, which will be based on a different asset mix. It's a hypothetical asset mix, as if you were going to go put your assets all into a couple of examples here would be US Treasuries or high yield corporate bonds. So basically what it ends up being is coming up with a lower discount rate, because it's meant to be a less risky discount rate, and it provides a higher liability number based on that lower discount rate. And ultimately what we're trying to show through this disclosure is the benefit of taking risk. So through the pension plan, the pension trustees are taking risk out in the market by buying stocks. You're getting a benefit from that through a lower liability and ultimately lower contributions from the plan sponsors. So this liability will help explain kind of the risk reward side of that analysis. There's also another provision in ASOP 4 that's new this year, and it's a requirement that if the actuary doesn't think that your contribution method is reasonable, so if we don't think that the way you're contributing to the pension plan isn't going to pay for the pension benefits over a reasonable period of time, then we must calculate a new reasonably actually determined contribution and disclose that. That one's probably less of an issue. Most pension plans are using what their actuary would deem as a reasonable actually determined contribution. So that one's probably not going to show up as much in your reports, but this LD-ROM thing definitely is going to be new and out there. So Chad, that was my very hot, very fast pension update.
No, that's great. And again, Kevin, you just hit it right on the mark. And so I think as you all are listening to Kevin speak, obviously a public act that's been around for quite some time, and yet action that you all are going to be required to take here in the nearer than longer future. And so we wanted to be sure that was continuing to be on everyone's radar and list of sort of to-dos in the not too distant future. One thing that I wanted to revisit from Gail's portion of the presentation was we had a chat come in around how drug pricing negotiations would affect Medicare Part D. I think, Gail, we really handled that in the entirety of your presentation, but I do wonder a little bit, I think it would be fair to say there are still some very real unknowns specific to that, and we're going to have to continue to track and watch for how specifically those renegotiations and negotiations are going to affect things long term. Would that be a fair statement? And
Yeah,
Gail,
I was on mute. Yeah. I mean, that's a fair statement. I mean, honestly, I'm learning every day as to what's going to happen in this plan. So it's a moving target. So it makes it a little bit more challenging to make decisions. But all I can tell you is that there's certain things that aren't going to change. You have to pass if you're an RDS plan, right? Got to pass. If you're in if you have an HDHP and you have retirees in there, you need to rethink that. So those are the things that you can do now. But some of these nuances relative to even the negotiation. So let's say that, Medicare comes out and they're the final negotiated rate. What does that do to your PBM agreement? What does that do to your PBM agreement relative to your non-Medicare retirees? So there's a whole bunch of stuff that's sort of unknown that we need to just kind of wait for some additional guidance. So every single day we get more, and every single day we're sort of forming sort of strategies. But right now we're just in a wait and see.
Oh, that's good. That's good. And Kevin, I'm going to give you an opportunity just in a moment for any parting thoughts specific to this pension space more broadly. If there's anything else parting that you'd like to share, maybe just a reiteration of how we help counties in Michigan and elsewhere with that pension piece specifically. But before I come back to you, I wanted to make everybody aware that we will be sharing today's presentation with Mac to share out with all of you. So be on the lookout for that. With that, we'll be providing an article, and Gail referenced this, around how you can maintain creditable coverage as we continue to navigate these Medicare changes. So real quickly, Kevin, before I wrap things, any other parting thoughts from a pension standpoint that you might want to share?
Sure. So when I think of your pension plan, it is a part of your benefit package that you are offering to your employees and your members of your various counties. And as we know, it has become harder and harder to attract and retain employees. So pension plans are a very important part of that as you compete for talent with the employers within your counties, as they have moved away from pension plans and you continue to provide those types of benefits. So as you think about that and think about how the pension plan fits into your overall strategy, I think it's important to make sure your employees really fully grasp what you're offering them. Pensions are an expensive endeavor. You want to make sure you're getting the most bang for your buck. So when you're thinking about your pension plan, really think about, how do I communicate this to my members? Make sure they fully appreciate the value that all of you are providing to them through the pension plan.
It's fantastic. So as we wrap up today, you see on the screen my contact information, my colleague Jeff's contact information. Really what you're experiencing today, I hope you're experiencing, this is why Jeff and I love being at Gallagher. We have a team of experts, not just here in Michigan, but across the country, who we really can bring to bear for the betterment of our clients and what they're doing from a people and benefit strategy perspective. And so if you have additional questions when you receive the deck, you receive the article, or based on some of the things you've heard here today, haven't maybe felt comfortable chatting that in as a question in the webinar setting, just know that Jeff and I are a text or an email or a phone call away. Please feel free to reach out, and we're happy to continue these conversations with you. We hope you all have a wonderful remainder of the week. Derek, I'll check in with you real quickly to see if there's any MAC specific business that we need to touch on before we wrap up the webinar.
No, thank you, Chad. Just thanks to all the members who found time to participate with us today. And we'll be getting these resources out, as you mentioned, Chad, to members who need to navigate this incredibly difficult issue.
Well, we thank all of you as well for taking time out of your busy schedules. Thank you to Mac for the opportunity to share this timely information, and we'll look forward to seeing hopefully all of you at the legislative conference next month. Have a great rest of the week and be well. Thank you.